Thank you. Good morning and welcome. We are at our Healthcare Services Review Project Committee. Today is October 15th and our start time is 8:34 a.m. Annette, can you please take roll call?
Yes. Supervisor Canepa? Supervisor Dean? County Administrator Regallo?
Here.
Ms. Hopkins?
Here.
Mr. Brucker?
Here.
County Counsel Kiernan?
Here.
Ms. Macedo? Mr. Woodcount? Ms. Valentine?
Present.
Mr. Castro? Here. Ms. Harlan? Here. And Mr. Garber?
Here.
Thank you. We have a quorum. The next on our agenda is the approval of the minutes from July 16th, 2025. If everyone has had a chance to review the minutes, if there are no changes, I will entertain a motion.
Motion to approve.
Genevieve can second.
All those in favor?
Aye.
Aye. Opposed? None. Passes unanimously. Thank you. Next, we have some information and discussion items. First, we have Matt Garber and Rachna Sharma to present the financial results for SJ Health.
All right, thank you. I'll turn it over to Rachna.
Thank you, ma'am. Good morning, everyone. My name is Rachna Sharma. I'm the controller in the finance department at SJ Health Centers. I will be presenting the financials for the month of August for SJ Health Centers. We are still working on the September financials, so this is the latest set of financials we have available at this moment. All right. So on this slide, what you are seeing is the billable visits for the last 36 months, trending from September 2022 to August 2023, September 23 through August 24. and then September 2024 through August 2025. The blue solid line is our current year and ending August 2025, not the current year, but the last current 12 months ending August 2025. The orange line reflects the billable visits for the 12 months ending August 2024, and the gray line that you are seeing is trending the billable visits ending the 12 months August 2023. So the August 2025 billable visits are showing the increasing trend, upward trend, which is in line with the 2 years ago, 11,442 visits compared to 12,936 visits, right? So which is in line, whereas the August 2024 visits were showing downward trend, mainly because we had lost few providers in the month of August 2024. That's why you are seeing a decline, so which is going in opposite direction. For the month of August, we have 11,442 billable visits compared to budgeted 11,062, showing a favorable variance of 380 visits. Overall, year-to-date for the 2 months ending August, we have actuals 22,500 billable visits compared to budgeted 22,648. Overall, year-to-date, we have unfavorable variance by 148 billable visits. When it comes to the, sure.
What, that spike, what is that, flu season or something? From 9,000 or 8,500 or 9,000 to 11,500 at the beginning? What, that's odd.
So
like-
for the
What caused that?
I would have to actually go back and check. Can I please get back to you on that one?
Because I mean, that,
Sure.
you don't see that anywhere else, and that looks like a major anomaly, and why would that be 2,500 visits in 1 month?
Sure,
I mean, unless it's flu season.
sure. I'll
Does
get
anybody-
back to you on that.
Does anybody else know?
Actually, it sounds like that was when
see.
we changed rates, so when the rates went down.
So this is also when we did satellite clinics and started moving individuals and hours different so that we had the accessibility increase.
Oh, okay,
Thank you.
perfect.
Um,
Sorry
So,
to interrupt.
no, you're fine. Thank you. So for the billable visits by financial class, majority of our billable visits pertain to Medi-Cal managed care patients, which is 77.82%. Medicare is 12.02%, Medi-Cal is 6.05%, commercial is 3.17%, and self-pay is 0.94%. So these billable visits are pretty much in line with the historical trend from prior months, prior years. I don't think I have much to talk about on this slide. Any questions on this one? All right, thank you. Income statement for the month of August. What you are seeing in the second and the third column is the current actual period revenues and expenses, whereas then you are seeing the budgeted revenues and expenses for the current month of August. And then there is a variance column, current period budget versus the actual. And then the last 3 columns reflect year-to-date numbers, the year-to-date actuals as of August, year-to-date budget as of August, and then year-to-date budget versus actual, the last column. So for the current month, we are showing the net income of $1.1 million compared to budgeted loss of $66,000 with a favorable variance of almost $1.2 million. Whereas year-to-date, as of August, we have $2.2 million in the net income compared to budgeted loss of $119,000 with a favorable variance of $2.3 million. Majority of this favorable result is really coming from the favorable salaries and benefits compared to budgeted. As you can see, salaries and wages and benefits lines in the middle section, the first 2 expense items under the expenditures, they're showing favorable variance and are really the reason for showing the favorable results. Because we still have a lot of vacancies, vacant positions that need to be filled, but we assume 100% employment day 1 of fiscal 26, but it takes time to fill the positions. That's why we are seeing favorable results. As the year progresses, as we are working hard to really fill the positions, hopefully the variances will come more in line with the expectations. But as of right now, we have favorable results on the payroll benefits and expense. Did you have a question? Sorry.
Yeah, just the supplemental, so on the revenue side of it, the QIP is 42% of which one of those revenues? Your little bookmark at the bottom of this.
Okay.
So it's
yes,
42% of which one of
yes.
those revenue base?
The supplemental revenue, which is right below which is the second row on the
Okay.
top, which is the QIP revenue.
Uh-huh.
So that is $2.2 million. So what you do is you take the QIP divided by the total operating revenue, $5.4 million in the middle section. That turns out to be 42.37%. That's what it reflects. So the total operating revenue as of August, which is 42% of the overall operating revenue. So that is really playing a big role in the survival of the organization, apart from bringing in the net patient service revenues. And the reason, if you really remember, last year we had this percentage 29%, and this year we have 42%, because the revenues that we are accruing is based on the information we have received from Toyon, which the outside consulting firm the hospital is using to do the calculations for the QIP revenues, and that's what the base budget is based on. And we are accruing the revenues based on the budgeted numbers. That's why on that particular line, supplemental revenue, you're not seeing any variance. It's zero, because whatever is budgeted is actually being accrued. And it will be trued up as we perform the year end due from reconciliation with the hospital, and we will true up the numbers. based on
Because
that.
reliance on that is not good to
Yes.
stay solvent. I mean, that, especially if it went up 13% in 1 year.
Yeah, 29% versus
The QIP was increased, so last year by 75%, so that's why you see a larger number this year.
and now the new pool is 85%.
Yeah.
But just
In
understand.
plain English, with, okay, 75% of what?
Let me make sure you
Of
understand
the
that.
total pool, I'm sorry.
They took money from a pool that the hospital received 100% of, which is the
GPP is 100% of,
They took that money and they moved it over to the QIP.
Yeah.
So the QIP money increased 75%. So that allocation, and again, you guys know how I feel about that QIP money. I'm never gonna, there is never a scenario where somebody sends you a check with the expectation that you send that money to somebody else. That's just, that's the, you guys know how I feel about that. But we can't take an additional, so we objected to the QIP at 34% of the smaller amount. We certainly object to the QIP now of 34% of a much bigger account, because we lose that whole account from the GPP money.
the GPP goes away in 2026 is what he's referring to. So right now, we retain, it's about $20 million that we receive through GPP,
And what's that acronym?
Global Payment
Program.
Program. So,
Okay.
but it's phasing out. So what
Okay.
they did was since it's phasing out, the state said, we'll take some money and put it over in QIP, because it's ran basically on quality metrics, right? And we're moving to more quality-based care. So the GPP will go away. So we'll lose the 20 million to our bottom line, because it's going over into another bucket that we currently share. So we will take a hit at some point in the year 2027 after the GPP phases out.
Chair,
hospital.
thank you for the question. I think part of this has to also do with the quality scores increasing, and so the amount of money that the county has received, which is under the board's jurisdiction, has increased. We talked about that last quarter. The county administrator's office and healthcare services are meeting in early November to discuss the MOU between the county, all of the county departments that support SJ Health, including the allocation split, and then the CAO's office, healthcare services, and the hospital will be meeting. So by next quarter, we should have at least a preliminary update and perhaps recommendations of what we want to do, recommend to the board moving forward related to the QIP money. Taking into account that both departments will receive probably significant federal and state cuts. So we're going to chat about that later this meeting, and then we're meeting with the department so that we can provide a better update next quarter to
Yeah, 'cause
your
we
board.
don't, that number's not trending in the right direction. I mean, especially if this money's going away and you're relying on it, and that's no bueno.
Correct. And we want to make sure we have a plan and a recommendation for the Board of Supervisors to consider.
Okay, thank you.
Just to add one more point to, thank you, Brandy and Sandra. One more point to add on is the $2.2 million also has embedded almost $83,000 in it as a reserve. Just in case if we don't end up receiving 100% of the $2.4 million, technically it is supposed to be somewhere around $2.3, $2.4 million, but we built in $1 million in reserve for in the budget, which is about $83,000 per month as a opposite entry to the revenue side, so that just in case things don't go the way we expect, at least there's some cushion.
Okay. And what's the multiplier? How many payroll cycles can you make? Is that what you guys are covering? So what's the safety net for an organization like SJ Health as far as being able to make payroll for how many?
So currently, when it comes to the cash situation, we have 246 days.
Okay.
And on hand, the number of days we can survive without bringing any additional dollar in as of August. So on average, somewhere around we have expenses about $125,000 to $128,000 per day, cash basis.
All right, perfect, thank you.
Sure. All right, thank you. So net patient service revenue, so I'll just start from the top, and I will point the major items that I would like to go over, and if you have any questions, please feel free to interrupt me. Net patient service revenue for the month of August is favorable by $165,000. Year to date, it is unfavorable by $16,000. The current month is favorable mainly because visits being higher than budget, and year to date unfavorable again, visits being lower than budget. So the dollars are in line with the trended billable visits. QIP, we just discussed. Capitation revenue is slightly lower than budgeted numbers, and we continue to see a declining trend in the physician capitation. We started the year with 38,000 membership assignments, and we are down to somewhere around 36,000. Last year, we started the year at 44,000 membership assignments. They're down to 39,000 as of June 30, 2025, when we had a meeting with the health plan. The reason being is that the major key player that is really causing the decline in the membership assignments is Kaiser. It is playing a big role. There are three key players in the health plans: HealthNet, Health Plan of San Joaquin, and Kaiser. And Kaiser is the main reason that is causing the reduction in the membership assignments. So that's the reason why you are seeing the actuals are slightly lower than the budgeted numbers.
And to add to that, we should anticipate an additional 10% reduction in the amount of individuals assigned due to HR 1 and other impacts with federal and state changes.
I can't remember on the default for that. Is it Kaiser the default now? Or?
So right now, Kaiser is the default until they hit their max amount of individuals based off of when they became a Medi-Cal provider in the county and a required statewide Medi-Cal operate. So they have to hit their threshold unless a beneficiary or consumer decides that they're going to select something different. But immediate enrollment is to Kaiser at this point.
So now they'll get those same DSNP folks too? I mean, so they're qualified?
That is correct.
All right.
Thank you.
More good news.
All right. No. Managed care incentives is pretty much the incentive revenue that we are accruing pertaining to the HEDIS block access program, HEDIS gap closure block access program that we have with the Health Plan of San Joaquin. Currently, the program is supposed to end somewhere around December 2026, and our actually accruals are pretty much in line with the actual payments that we are receiving from the health plan. The latest payment that we have received, I believe, is as of June 2025. So the accruals are pretty much in line. Grant revenues, we are seeing $81,000 compared to budgeted $41,000. Even year-to-date is slightly higher by a favorable variance of $75K. It is mainly related to the ARPA grant project that we have on the books and which is supposed to expire December 2026. The reason for the favorable variance is we have additional employees that are being charged to the grant project, which were not budgeted. At the time we prepared the budget, we didn't have that information. So the grant project manager is assigning more staff to this grant project, therefore we are accruing more revenue. The 340B pharmacy program has a favorable variance of $23,000 in the current month, $16,000 year to date, mainly because of assigning the Walgreens pharmacy to various manufacturers. Prior to that, they had manufacturer restrictions where the discounted prices will be given only at specific locations. And now since the manufacturers are lifting away those restrictions, and so we have been able to actually process more claim assigned to more locations. So that's the reason why we are seeing a little bit of revenue being higher than budget. MOU and other income. So the current month is slightly lower, whereas year-to-date it's slightly higher. It's mainly because of the interest income recorded in the month of July based on the higher cash monies sitting in the county main treasury account from where we actually accrue the interest. So $15,000 favorable year-to-date MOU and other income line is really related to the interest income we have recorded in the month of July. That's pretty much it on the revenue side. Expenditures, salaries and wages and benefits. We are still seeing favorable variances mainly because we have a lot of vacant positions. As of August, we had budgeted 239 FTEs in the budget, whereas actuals have been 184 as of August. Professional fees is, question, anybody has
What was
question?
that again, to what?
239 FTEs,
And you had what?
184.
To provide clarity, though, that is based off of county employment. We have over 70 locums between doctors, nurses, and other classifications. So we're technically exceeding the amount of FTE, but it's a combination between temporary staff, locum staff, and county staff.
So the 170 plus 70 puts you at 240, and we budget how many? 229?
239.
239, so you're 4 over, okay.
Professional fees is pretty much in line. Year-to-date, we are seeing, let me see, yeah, unfavorable, mainly 1.1 million versus 1.083 million. It's mainly because of the excessive use. I wouldn't say excessive, but I would say actual usage being higher than budgeted pertaining to the medical contracted staff, like Genevieve mentioned. We are hiring a lot of locums and medical staff through Barton and Associates, which is actually causing the variance, unfavorable variance right now. Purchase services are pretty much in line, so there's nothing to talk about that. Supplies, we are seeing unfavorable variances mainly related to the 340B pharmacy program. As our revenue is higher, we are seeing more pharmaceutical drugs being ordered as well under the program, and that's causing the supplies to be higher. The next category I would like to bring it to your attention is the dues, subscriptions, and fees. Again, this is pertaining to the 340B pharmacy program because we have TPA fees being charged and recorded under this category. As we are seeing more revenue, as we are seeing more pharmaceutical expenses, we are also seeing the TPA charges being higher than budget. Other than that, I would like to go over the travel and training, which is also unfavorable. That is again pertaining to the locums we are hiring through Barton and Associates. Most of these locums are out of state, so we are also covering and reimbursing for their travel and lodging. That's why we have unfavorable variances there. Along with that, we are seeing unfavorable variances from the insurance category as well, which is again related to the medical contracted staff. We are paying malpractice insurance to Barton and Associates, and that's which was not part of the budget. When the budget was prepared, we had somewhere around 5 to 6 locums budgeted, whereas the actual usage is 8 to 9, so which is really causing the unfavorable variance right now. Other than that, Rest of the categories are pretty much okay. As the year progresses, we will see the revenues and expense items to becoming more in line. We start hiring more people, we will see the salaries variances, favorable variances to go down. So the efforts are being put. We are actively trying to fill the vacant positions, but as of right now, we have $2.2 million in net income compared to budgeted $199,000 loss for the 2 months, mainly because of favorable QIP and salaries and benefits really offsetting rest of the expenses.
I do have a question, please. I
Sure.
think for Genevieve. We talked about the 184 FTEs and the 70 locums, so total budgeted is 239, so we're over. But are we trying to, and I know that you are, but if you could explain a little bit what we are doing to try and right-size? Because I would imagine you are going to have some locums, but maybe not at the 70 level. And so what we're doing to maybe right-size so that we get the budget correct? And
Absolutely.
thank you.
So Matt, please jump in to elaborate as well. So Healthcare Services has come in with a variety of executive leadership to look and assess staffing ratios, the type of classifications to right size from a county personnel perspective, the right classifications and the right jobs. And in the right duties. So who should be at certain clinics, who should be managing, and restructuring it in order to make sure that we're actually hiring from a county perspective and not from a consultant perspective. That could be anything from our IT and CIO perspective to even some of our data analysis staff. So there are individuals that are non-revenue producing individuals that we have that are on contract. So we have been working with downtown HR in order to create the correct classifications for the clinics in order to meet those needs. But we're also looking at where there are, I'm going to say, fluff positions that are not the right classifications for the duties that need to be done within clinic operations. So we have done a full assessment. By the end of October, we will have July, August, September, and October, so 4 months of full assessment so that we can at mid-year be able to actually either convert or ask for the appropriate classifications in order to reduce professional services and obtain the staffing that we really need. For example, we have a large pool of medical assistants that we have budgeted and allocated. However, we really need 7 more RNs. And so when you are getting RNs from a locum company, you're paying at a higher rate rather than having the classifications that you really need. So how do we potentially swap out some of those positions for the positions that we really need and are able to then actually bring in revenue for those additional positions at a better rate as well.
And I'll just add briefly that we've started also with really the higher level executives. We have our CIO's contract terminating at the end of December. We ended our contract with the contractor that was doing our chief of nursing duties, and was able to confirm yesterday with Dr. Dulio that as far as physicians, we only have 6 locums physicians, and 3 of those are required by the health plan of San Joaquin, which funds them, and they require that they be locums. So we're at least down on physician positions.
Please keep in mind that-
CIO, I don't.
Oh, I'm sorry,
the
Chief
act-
Information Officer.
Okay.
So if you look at the 70 locum or contract staff, only 7 are physicians. So we definitely had a stray from county vision and mission, which is why we're trying to get that back in alignment.
Thank you.
I just had one question. So on the pharmacy thing, it sounded like the 340B thing was a good thing, and then on the other side, you said that it was part of more expenses. Can you explain that? I don't understand that. So
Yes.
you said you were getting open lower prices on prescriptions, but then it increased supplies.
So these are
How's
the
that work?
actual savings that we have on the revenue side, the 340B pharmacy program. We are getting discounted prices from the manufacturers when we are serving the underprivileged community. So the savings are over there, but at the same time, part of that, so the dues and subscriptions category is not 100%. The TPA fees, there are software subscriptions as well amortized there. So
TPA acronyms, I'm not a big acronym guy, so TPA, I gotta
Oh, third-party administrator.
Okay, all right.
Yeah, so we have third-party administrator firms like Nuvom, we have a Wells Partner, the organizations that specialize in accounting for these programs like the 340B. So they are actually administering the activity that is taking place under the 340 pharmacy program we have with different manufacturers. So we have contracts with Nuvom, they charge a certain fees providing these services and actually tracking the activity taking place and reconciling, and that's why we have to pay them the third-party consulting fees, basically.
Okay, and that's in supplies?
That's sitting in the dues, subscriptions, and fees category, the fees that we are paying to the third-party administrator firms.
Okay, but so
The
why did the
supplies are
supplies go up? Why is there such a disparity? Is what I'm-
Because the thing is, we did not budget for the supplies at the time when the budget was being prepared. But then after the budget was prepared, the additional pharmacy was added, designated under the account network. And then we started seeing more claims. And then we are also seeing more activity taking place now on the pharmaceutical side under that program.
Okay. Thanks.
Sure.
And to add to that, eventually you will actually see the clinic's budget from a county budget perspective. Right now, some of our budget is outside of the county process. So this upcoming fiscal year, it'll all be combined into a traditional county budget and not us having two separate budgets operating at one time. So I do want to thank Adam, who has been working with us diligently in order to make sure that all of the health clinic's budget is at one place in one location in order for us to have better transparency.
Thank you, Genevieve. All right. So I think that's what I had on this slide. Any other questions? All right. So the next slide that we have is just the variances that I've already gone over in the previous slides. So unless you would like me to go over anything particular on this one. All right. So the next slide we have is the balance sheet. So what you are seeing on this slide is our unaudited results on the balance sheet as of June 30, 2025, fiscal 2025. Then you are seeing the balances as of July and as of August. So the cash and cash equivalents, you are seeing that there's a slight increase in the month of July in cash compared to the June financials. The reason being that we had medical withholds that take place every year, May to June, so we stopped receiving the monies from state. So we had lower cash balance, but which is reflected as receivable under the accounts receivable category. And the next month in July, you see an increase in cash and decline in receivable, which are in line with each other. So those monies were received in the month of July, so the cash is going up and your receivables are going down. So they are in line, and in the month of August, business as usual. So on normal basis, accounts receivable is somewhere around $2 million, and the cash is also in line. Property, plant and equipment, there is just a reduction going on right now. It's mainly because we are recording the depreciation expense offsetting the assets. Other asset category, you are seeing over here, you are seeing increase in the other assets. Part of the reason mainly is really the increased QIP revenue that we are recording to the receivables. So as of June, we were recording the receivables at the QIP revenue was $1.5 million per month, whereas now, as we can see, we are accruing $2.2 million. Majority of this increase in the other assets category is mainly related to the QIP. Along with that is the grant receivables being recorded there as well, the 340B pharmacy program receivables as well. The other major components that are part of the other assets is really the due from DHCS, CMS, prepaids, and those categories. Under the liabilities, you are seeing slight reduction in the accounts payable, which is based on the actual business being done. So sometimes we have less invoices received or the processing time. It is just the matter of the timing when the invoices are received and accrued. Other liabilities, as you can see, have gone up. We finished the year at $5.9 million. And in July and August, the liabilities are higher because Other liabilities include the payroll liabilities, and other liabilities basically is our the Manteca Clinic lease, the finance costs we have, they are also part of other liabilities. Due to state also are part of the liabilities. But majority of the increase is really related to every year, every month we make a reimbursement payment to the county for the payroll services, the employees being paid, and then we reimburse the county because the employees are on SJC's books, not on SJ Health Center's books. So the payroll is taken care of the county, and we make the payment to the county for the payroll deposits made to the employees for the prior month in the following month. So when it comes to June, the year end, we pay off all the liabilities owed to the county within the same month to close the books with almost a zero balance. Whereas in the month of July, business becomes as usual. We accrue, we pay in the following month back to the county, make the reimbursement payment. So the July and August are really showing the liabilities reestablished, whereas in the month of June, the balances were paid off to the county for the monies owed to SJC. The next category I would like to really point out is $1.6 million under the restricted net assets, which is really the funds being received from various grant funding agencies that we have not been able to spend yet. And they are just sitting as deferred revenues, restricted net assets on the books. These funds cannot be used to any other purpose until we need verification and approvals from the grant funding agencies, whether we will be okay to reallocate the funds for different other purposes, or we will need to return these funds, or we just are going to extend the grant projects if we get the approval from the funding agencies. In the meantime, they are just sitting in the restricted net assets so that they can't be touched and used for any other purpose.
Quick question, have we got a grant writer?
I'm sorry?
Do we have a grant writer?
No.
I think that's a shortcoming for both
Yeah.
you and I.
Yes, yes.
So I think
We
need to-
definitely need one dedicated staff who is overseeing the grants portfolio, the grant manager or the grant administrator or the grant writer, somebody who is really overseeing the activity and follows up on
And
it.
it would just take one small grant to pay that salary, so I would
Yeah.
highly encourage that we push hard to fill that
Definitely we
position.
need one.
What's under other assets? So that went up 4 times, 4 million, right? So what is that?
Yes.
Why would it increase so much month to month?
So the other assets include the prepaids, the due to from between the hospital, the DHCS state, the CMS Medicare, grants receivable, QIP reserve, 340B pharmacy program receivables, and that's pretty much it. The reason for the increase mainly is an increase in the QIP revenues that we are recording. We don't get paid right away. So we normally get paid from the hospital during April or May of each year once they have received the payment from the state. In the meantime, we keep on accruing the revenue and increase the receivable from the hospital. So that's really part of the reason why we are seeing an increase from $15 million to 17, then to 19. We were accruing somewhere around $1.2 to $1.3 million per month in QIP revenues last year. But as of July, as we have seen, we are accruing $2.2 million per month. So there's a right away more than $1 million increase in the QIP.
So you're showing it on
So
the books. You're showing it on the books, but you receive it annually.
Yes,
Okay.
yes.
I also do want to add, just for transparency, the increase in QIP is not just going to sit on the books in the SJ Health clinics. The additional revenue and other cash will actually be allotted to the Be Well campus and pay for the urgent care construction of the SJ Health clinics, urgent care, and the outpatient mat services. So we have not included in the Be Well budget, both for the overall project at large, because we didn't know what the construction cost would be for the urgent care and sobering center that will be operated by the SJ Health clinics. So we are almost done with actually getting that specific construction and infrastructure cost. And so the additional QIP, the additional cash will actually be moved from the SJ clinics cash reserve budget and moved into GSD's Be Well capital project in order to pay for the construction. The actual services provided in 2028 will actually allow for additional access points, increase PPS rates, and also will be able to long-term give us the ability to provide MAT services, medication assistant treatment, opiate treatment by the FQHC, which they do not currently do. So being able to use those increased dollars and the additional cash to invest in the specific location at Be Well will allow us to have increased PPS rates, additional services, and offload things that would normally hit an ER to do better outpatient services from a larger holistic perspective.
So that increase comes directly from the hospital. It's really important for everyone to understand that. That's that 75%. We went from 1 million a month now to, or 1.2 million a month to 2.2 million a month. Guys, we're struggling too. We're struggling too. And that QUIP money, I'm going to continue to push the issue that that's hospital money. And I'm very concerned about taking the overall financial operations and extending that to other projects to make them whole. I just don't think I don't think you'd see that in any other public hospital. I know you wouldn't see that in any other public hospital. And we can't afford another $12 million from our payroll to the FQ payroll, and I'll say it, and I know you guys are tired of hearing it. I'll give the broken record over and over again. CMC receives no public funds. Golden Valley receives no public funds. The delta between the actual revenue produced from the clinics and the cost of the clinics is being funded through the QUIP money, and it doesn't exist outside of that in any of the other private sectors. And I know you're tired of hearing about it, but I would be remiss in my job if I didn't point out the fact that there's a significant, what looks really good financially, and I love these guys, I know they're doing a good job, but I can't sit here and say that we can continue to run a clinic system that's really producing about $25 million in revenue and costing 48 in expenses, and the hospital's covering them.
The only thing I'd like to add, though, is when you look at the QIP measures, not all of them are the hospital measures. So there are outpatient measures. So yes, I agree with Rick that there is changes that we need to make in terms of the percentages in order to have both sustainable for integrated care, but we do need to make sure that we are aware of and it's acknowledged that the QIP measures are both inpatient and outpatient. And so there's shared responsibility with both the clinics and the hospital, but also behavioral health, because a couple of the measures in the QIP is actually pulled from the data of behavioral health, not from either the hospital or the clinics at large.
Thank you, Jen. All right, so that's all I had really on this slide. We can go to the next slide. So on this slide, what you're seeing is the actual cash collections reflected for the last 36 months. Again, same colors. The blue line is the recent last 12 months. Orange is for the 12 months ending August 2024, and the gray line is actually ending the 12 months August 2023. When you are looking at the blue solid line, the very top line, the solid portion of the line is the actual collections for those months, whereas the dotted blue line reflects the estimated collections for those months. As we all know that we recently implemented the intermittent clinic strategy back in September 2024, and these financials are as of August, and it takes time to really receive all the information when it comes to analyzing the actual collections data. And we need more months, actually, maybe it will take 1 year, 2 years, 3 years to fully analyze what our actual collections are based on the claims processed. So there is a point where you really have to make the estimates based on the actual billable visits and the historical data for the actual collections being received. From that time frame, September 2024 is when the intermittent clinic strategy was implemented. That's why you can see that in the month of September, your collections are really high with the solid blue line, and then the blue line is really above any of the last, the first 2 years, the first 24 months, is because of the increased cash collections as a result of implementing the intermittent clinic strategy, where we have 3 clinics in one location, other 3 clinics in another location, and we have a parent clinic under which we have started billing the claims for the 2 children clinics. So that's really the intermittent clinic, where you have changed, updated the rates that you're going to be using to charge for the claims for the children under the parent clinic's rate. That rate is higher than the children clinic rates. So we implemented back in September, and our collections have really improved big time. And so from the month of March.
Rachna, I'm sorry to interrupt, but we're running short on time. If we could just wrap up at this slide.
Sure, thank you.
Thank you.
So from the month of March through August 2025, we have estimated collections based on the historical trend we are seeing. And when it comes to the collections by financial class, majority of our collections are really coming from Medicaid, then 94.21%, Medicare 4.92%, commercial 0.75%, and self-pay is 0.12%, which is mainly in line with the historical trend. The percentages are pretty much similar to the data we have presented in the past.
Thank you,
Director
Raj.
Valentine and Director Garber, this prompt reminded me that we had agreed that after a year, we would have an intermittent clinic strategy discussion here. So can we bring that next quarter, please? Thank you.
Thank you.
Thank you, Rachna.
Any questions on this slide?
No, I don't believe so. And on the next slide, if I could just add, these are benchmarks, and it looks like the clinics have met all of their benchmarks. So
Yes.
unless anyone has questions, we can proceed.
Sure.
Do
I
the-
would like to actually just mention that we are seeing the numbers in green. The reason being is because of the increased QIP revenues that we have accrued for, because they play a big role in increasing the bottom line. And these percentages are based on the operating revenues. And since the revenues are higher, that's why the increase is reflected in the green lines. Otherwise, if you take off the additional $1 million in QIP revenues that we have accrued, you'll be back to somewhere around 8 to 10% percent in the operating margin, bottom line margin. Other than that, yes, the 64% in the personnel related is really also a result of increased QIP revenue accruals. I think that's all I wanted to mention.
Understood. Thank you.
Thank you.
If there are no questions,
I think that's pretty much it on my side. Any
Okay.
questions, comments?
we will move on. Thank you.
Thank you, everyone.
Next, we have Sam Harlan to present the financial results for the San Joaquin General Hospital.
Thank you.
Appreciate it. Okay, appreciate it. Thank you.
Go ahead.
He said 1 second. Okay, I had to wait for the thumbs up, so I waited for the thumbs up. So we will present what we finalized for last year and what we're currently going under audit for. We're still working on our first quarter stuff, which is due to Mr. Adam on Friday. I will meet my deadline, I promise. So this is currently unaudited. At this point in time, we're currently undergoing audit, which is always a fun time of the year. But we've had several successful audits in the last few years, and we plan on having a successful audit this year. So this is just a quick slide of some of the major buckets of utilization that we have. We have ED visits at the first little square and surgery visits at the second square. Both of those categories are above budget and above prior year, last fiscal year, 2024. So both of those buckets are higher than what we budgeted and what we actually had been able to utilize in the previous year. Patient days and discharges are slightly down from budget, but they're equal to prior years. So the volumes are basically the same, but we had projected and hoped to have a little bit more inpatient utilization. But as Rick will tell you, we're full on most days. So it's hard to get more volume in the door, but we're still working on it, trying to reduce our length of stay so that we can actually throughput more patients. And you'll see that in another slide. So the next slide is our case mix index, which is the acuity of our patients. So how sick are the patients that we are taking care of? And are we actually capturing in our documentation the appropriate things needed to reflect what we actually did to take care of our patients? So this is a very critical factor for us. We have several things that we've implemented since Rick came on board. We have the Clinical Documentation Improvement Program, which is the CDI program, that has the nurses reviewing the records to make sure that the documentation is captured. They can send out inquiries and say, I see you did this versus this. Can you clarify that for us? So over since 2021 and up into current, we've seen an increase in and a steady increase in Medicare at 2.0. For CDCR, we're steady in that one, a little increase over time, right, at 1.79. We've seen a slight little decrease of 0.02% in our overall, which means every payer. But overall, this is a great improvement from what was happening 3 years ago, which affects the bottom line. If we can make sure that we code correctly based on the documentation, we can bill at the appropriate level and collect at the appropriate level for the costs that we've had to take care of the patients.
So prior to the MSA, our overall CMI ran at 1.37. And
That's a primary care hospital.
that's basically we're
Yeah,
delivering babies.
not trauma.
Yeah, not trauma. So every one of those decimal points, every point, like 0.1, represents hundreds of thousands of dollars. So when you look at the 39 million improvement we've had financially overall, this is probably responsible for about 40% of that improvement.
The next slide is a little busy. Didn't know it was going to look like this actually on the screen, but this is the average length of stay. So this is another indicator that we track and monitor. And if we can reduce this number, we increase our net patient revenue. So basically, if we can stay within the geometric length of stay of what's expected for us, if a patient comes in, they should be released in 3 days. If we release them in 3 days, we get the full payment, we cover our cost. If we release them and they improve less, then we make a little profit. But anytime you go over that, then you have costs that are incurred that you're not getting reimbursed for. So some points in time in here, we hit the 4.7, 4.6. Rick has set a goal for our case management team to be 4.5. We're at 5.1 right now. A lot of that has to do with the patient population that we take care of and being able to discharge them. You can't discharge someone with a wound to a camp. You can't discharge them to a SNF if they don't have really good benefits. So we face challenges on that area, probably more so than other hospitals in the area because of the patients that we take care of. But we're working on improving the case management in the hospital to be able to reduce that. And every time you reduce that by 1 day, you pick up really millions of dollars in our situation.
What, if they come back, does that add to this average, or does it start anew?
Within 30 days, if they come back, we don't get paid at all. So we can't.
So we have to watch our readmissions.
We have to watch our readmission.
But we did start the transition of care clinic, if you wanted to talk about that, to help with the
Yeah.
readmission rate.
So a couple of things that, and our readmission rate's not bad, but a couple of things that we've done is all of our discharge now see a clinic immediately to make sure that they get their DMEs, they get their prescriptions filled, they have a follow-up usually with the clinics, and that prevents the readmissions, and we're very good on that. The length of stay has to decrease because that's kind of the only opportunity we have left from a cost savings perspective. But I'll give you just an example of the challenge about, we had a patient, 750 pounds, in the hospital. Nobody would take them. And our only opportunity was to continue to push
dietary restrictions to get that person to a point that we could discharge to a post-acute. He, I believe, was with us for 253 days. We got paid for 3. And if you think that every one of those other 250 at about $2,000 a day, those are the challenges that are unique to county hospitals overall. So those are some of the challenges that we have in reducing that length of stay. But it's mandatory that we do it. Like I said, it's probably one of our only opportunities left from a financial pickup perspective.
From a healthcare services perspective, we're trying to actually find other alternatives for placement so that length of stay for the hospital actually can decrease. So the housing options and respite hospice for phase 2 of Be Well will actually help with length of stay. The health clinics are also assessing PACE housing and PACE outpatient clinics in order to help for those that are the seniors who might be lingering in the hospital but could actually move out. So in order to help the hospital's length of stay, but also good patient care and integrated health care, we're trying to look at other alternatives for post-hospitalization opportunities.
Not, I know it's HIPAA, but what's his weight now?
He's gone, so I don't know.
Oh,
We got it, I know we
sorry,
dropped it
I was
over-
scrolling there.
We
so.
dropped it over 100 pounds. But it was.
But I mean, that'll,
It was a
that'll mess
challenge,
with the averages when you got somebody for 253 days.
It's-
No, it does.
And we
but-
have several
yeah,
at any given
So we
time,
look at it from 2
unfortunately.
perspectives. We look at the length of stay for normality, basically. Did our pneumonias get out, pneumonia, sepsis get out in time? And then we take that other number, which is the number, which is this number here. But it's the number affected by all of those. Sorry. I've never needed a microphone, but, so we look at it from both perspectives because those unavoidables are just unavoidable, and all we try to do is make sure that we address it as quickly as we possibly can. We look for partnerships with our post-acutes as well, but, you know, the first question that they always say is, send us a face sheet. And we send them a face sheet, and they say it's a Medi-Cal managed care, and they all of a sudden don't have any room. So it's a challenge.
And to address the long length of stays, we do have what we have initiated with clinical and financial meeting once a week to go over all of the higher length of stays to see how we're progressing every week and if there's anything we can do, any barriers we can break down to be able to discharge the patient appropriately. This next slide is the year-over-year analysis from fiscal year 2019 into the fiscal year of 2025. There's been improvements along the spectrum of each one of these years. We ended fiscal year 24-25 with 28 million. Don't get excited, that was not all on our part. We did have a nice pickup of 18 million for our pension adjustment at the end of the year. And we had one in the prior year as well. So we accrue for pension based on what we're expecting. Actuaries get in there and do what they do, which is way above my head, even as an accountant, and decide, hey, this is what your reserve needs to be, and then we get an adjustment at the end of the year. So if you factor that out, we would be at a $10.4 million operating profit for this year. I will say not all of that's operational. We did have
Yes, it
some.
is. Yes, it is. Don't
He would
listen
like
to
you
her.
to think
Don't
that,
listen to her.
but as I would be remiss not to say that we did get some pickups in QIP of the 75% that we weren't expecting, right? So that helped us this year. We will have some challenges next year, which with the new HR1 and cuts, and so we will have continual budget meetings to make sure that we're making the adjustments that we need to make on our side to be able to see a continued positive, because we do take this cash that we do actually make at the end of the year, and we put that into capital. So the majority of the cash that we've actually made over the last couple of years, the county's been we've been very fortunate that the county has given us a large capital bucket to improve our plant operations, but also improve the equipment that we need to serve the patients. So we're very thankful at the hospital to be able to get capital and be able to replace things that are definitely needed, such as birthing beds and, you know, sometimes a robot to increase our robotic surgeries. But so for fiscal year 24-25, we actually ended up in a positive position. But I will go ahead and say, since we have these quarterlies, that will be a challenge in the coming year. And not because of operations, but because the government decided to make some drastic changes.
So our two areas of opportunity are the length of stay, which we just talked about. We have a plan to put some different leadership in length of stay and also denials, and that's the insurance company's battle. And it's, every hospital does this of they will deny claims for the sake of doing that. We're putting a very aggressive person in that position to fight the insurance companies harder. We know it'll improve from the run rate. There'll still be a significant denial loss, as is true for all hospitals. When we talk legislatively about what can legislatures do for us, the biggest conversation, I think, from all hospitals is stop this. Because when you look at, and I'll give you an example, we got denied for an inpatient status on a patient that was intubated, meaning we had to put a tube down their throat to help them breathe. And somehow Aetna didn't feel that met the criteria for inpatient status. Now we ended up getting the collection after months and months of providing more and more data to get something that they knew in the very beginning was an appropriate admission. So when we talk to the legislatures, we're saying, put a stop to this. This isn't, where else in the world do you send somebody a bill and they pay you what they think they should? I'd love to do that. I would send my mortgage company a lot less every single month, but that's the, those are the opportunities that I think overall, from a county perspective, to understand and keep pushing for those kind of changes, because we're really fighting, we're spending a lot of money to collect the money that we deserved in the first place. The length of stay is our responsibility, and we have a plan in place because we're running out of, the challenge for the hospital, if you look at where we've seen increases, we've seen them on the OR side, which is critical because that's where we have capacity. We can do as many outpatient surgeries as we want because we don't have to have a bed for them in the hospital at the end of the day. Or on the inpatient side, every single day we have 30 or 40 patients sitting in hallways and ER, and we're addressing that to get us back to the break even, but that's going to continue to be a challenge. And the ER is another opportunity for increased revenue, and you see the numbers there. They've done an amazing job. The ER was probably built to see 80 patients a day. At times we see over 200, so we're very proud of a lot of things that we do. We're very nervous about the challenges of the one that we're fighting right now is the DISH money. It could be a $15 million negative hit. I do believe we're going to get it. At the end of the day, we're going to see that money come back to us. But those challenges are the few things that make me roll over a few more times in the middle of the night. So.
Rick and Sam, will you be prepared to discuss that at our legislative advocacy meetings on Monday, please?
Excuse me, I'm sorry.
CEO Castro just mentioned what we need legislatively, so if we can have some examples and be prepared when we meet with our legislative advocates on Monday, because that meeting's coming up on the 20th. Thank you.
So then, what I don't understand is you bill such little amount. So how, is that just because emergency room visits are that high?
No,
Because
we
on the stats.
we bill a ton.
Oh,
So we bill $1 million, we collect 100. I mean, we receive about 11%.
but is it mostly through the ER? Because I mean, if it's all that's not Medi-Cal, then you're saying they're not paying, right? It's
No, if you think of
third-party
the ER from a perspective of a fixed cost, because essentially you have the nurses, you have the doctors, that's all in there. Every one of those patients generates income of somewhere between on the low side $600 or $700, and on the high side maybe in the mid $12,000-$13,000. So the more that we can push through areas of
Higher reimbursement. It's the OR pay,
yeah.
the OR reimburses
just
us
any
better.
added to
Yeah.
a fixed cost is an added revenue. So the OR is the same thing, and the OR is, the one challenge we're having right now is with GI, but we think we have a solution for that. But the OR just continues to, I mean, you saw the numbers, they continue to run all 7. We've taken the OB ORs, and we've actually used one of them for GYNs to add to that as well. and we're looking at the opportunity to add an eighth OR as well, because that's the opportunities for high margin, no increased cost business, and so that's what we're pushing.
I don't want to give off the impression, though, that Medi-Cal is not doing denials or errors. From a behavioral health perspective, every month we're being denied anywhere from 24 to 30% of our service delivery. Prior to payment reform, it was 7%. So BHS specifically is actually appealing a great deal of the denials and errors based off of the new payment source and so forth. Only 4 counties who've actually did a full appeal to the state have actually won. The state gets to make the determination on if they're denying or the errors, but then they are also the judge and jury. So it is not just commercial insurance that are doing denials at this point. It is across the board.
And legislatively, the 2 biggest lobbyist groups are health insurance and pharmacies.
And unfortunately, the health insurances such as Aetna and Cigna have started a new era where they are going to lower our coding and pay us on a lower code, and then we have to appeal it to get up to what it really should be. So there's going to be continued challenges, but we do have denials meetings, and I want to say I'm very proud of the revenue cycle team who have come together over the last 3 years. We were able to reduce our denials 7.8% from 2024 to 2025. And that's millions of dollars, and that's only through the efforts of those leaders and the team members working those accounts and fighting for every penny. So I'd like to make sure I give out some props to the team members because they've done a very good job.
The reason I bring it up here, this is because I always have a motivation. We're going to need to, in a sense, get a different position from a denials management perspective. Not an added employee, but a change of an employee to somebody we think will be very effective in trying to fix this on the front side. Challenging the insurers to say, this is what we have, this is what we're doing. I can look at the medical records and get that approval in the beginning so we don't have to fight it so much on the backside. But if we do have to fight it on the backside, this guy's going to be the kind of bulldog that we want to fight that battle. But I'll eventually have to come for a position change. So.
Oh, and with that being said, there is not a single position in behavioral health or public health who actually does that on the front end. So there is not a single position or an individual that does it on the front end in either of those departments that do have Medi-Cal billing. There is, I think, 2 positions total even in the health clinics. So it is a across-the-board issue for healthcare service departments in the county for those that are actually doing the front-end assessment of insurance and setting it up from a holistic perspective.
And I would like to just advocate that that would be a single entity that covered all 3.
Yes.
So we could, use the power of one to affect reimbursement on all behavioral.
That position would pay for itself, basically.
In a-
I mean, if
in
you
a
have
heartbeat.
somebody
Would more
getting
than
back,
pay for itself.
Then, yeah, that makes sense. Okay.
Just to give you a general overview of supplemental funding, which is where we receive a lot of our money, which is currently being affected by some of the governmental actions. We had a good year for fiscal year 2025. There were some pickups that we had in some supplemental funding programs that CAPH was able to get legislatively for us, who is our advocate, because they could see maybe the future down the line. GPP is going to be going away, which is the $22 million, which is also interlinked with some DISH funding. So we'll see that one transition out at the end of next fiscal year. But we have in our budget estimated to collect $166 million of supplemental funding. So I just want to keep y'all apprised of that's a big bucket of money for us, and it is something that we've worked very hard to try to maintain the factors that are needed and to get the points and to meet the metrics to be able to receive that funding from the government.
Sam, what is the position, the second line down, physician SPA interim payment of 2.5 this year?
Oh, this year? Well, Sometimes it's a smaller one, and sometimes we get the 2.5, sometimes we don't. Last year, say we didn't get it, but this year we can. It is due to the professional billing. And so we submit data to them, and then they will reimburse us.
Okay, thank you.
The DISH acronym is what?
Disproportionate share.
What is
Meaning-
DSH?
meaning-
What's DSH?
Disproportionate share, we just call it dish. It's
Oh,
one word, but
oh.
I don't know why we take 3 of them out of that word,
Oh,
but
yeah, okay,
anyway.
I get it, okay.
But for the underserved population, which is one that Rick alluded to, that with this government shutdown and they can't get into the chambers to vote to extend the DISH program, many years it's on the chopping block, but we are hopeful because a lot of the states that are rural depend on this funding. Red states, we're hoping that since we're in a Republican Congress, they will extend it.
For 25 years, it's been on the chopping block,
Yeah.
and so every year they're gonna cut it, and every year at the end.
Every year
end of
he
the
doesn't
year,
worry
they-
about it, every year I
Yeah.
worry about it.
And
So
they-
that's the global payment program
Yeah.
too?
Yeah.
Yeah. It's intertwined with, we get our DISH money through the global payment. When the global payment goes away, that's the reason why they're trying to increase it on the QUIP side so that we don't see as big a hit.
I'm very confident that DISH will come back. I'm the optimist, she's the pessimist. I just want to point that out
Imagine
to
that.
everyone. Yeah.
I concur with that.
Well, I will continue to be conservative to make sure that we don't get a surprise at the end of the year. How about that? And then this next slide is just the current projects that we have going on at the hospital. We have a lot of activity, a lot of projects going on, which will improve our operations greatly. The more data that we have, the better we can provide operations with the information they need in order to make adjustments throughout the year and not just one time a year. So the time clock project, which has been going on for a while, which I will say with so many MOUs, and hospital payroll is the most difficult payroll that you could ever, coming from an accountant perspective, could ever do in your life. Then you add 10 MOUs and several bargaining units that can make it a challenge. But we've extended it from December to January, which shows on this slide. We just made that extension because we are going through the first stage of testing right now. We are about to begin the second stage of testing, which will then hit in December, and then it was decided maybe that wasn't the best idea to go live due to vacations during the holiday period. So our estimated date is January. That will give us the ability to have real-time data of who is on campus at what time, what our patient census is, in order to be able to make sure that we have the appropriate staffing, since that's one of our largest line items. The next one is our CAC, our computer-assisted coding. That's in January, so we'll basically, it's a system that uses AI-type analysis to help assist in assigning a code, and then we can have someone else review it. It should improve our coding because it is what it is, right? It's black and white, but then having somebody else look at it on the coding perspective, then we'll also be able to help reduce some of the backlogs in coding, get the bills out quicker. So we should see an improvement in our turnaround time for our billing and coding. Workday Financials, as everybody in this room understands, is a big project where we're taking our financial system from PeopleSoft to Workday. So we expect to go live on that in February 26th. That's a really large area for the hospital. As y'all can tell, hospital operations are very complicated, so it's a very big build for us, and we have a large inventory system, which is the largest in the county, so it's taken some resources from the accountants, and why we haven't finished our quarter one, because we're trying to build the system to make sure that it's going to function for the hospital. QSite is a high-dollar inventory management system that will go live with Workday. That is our implants and high-dollar inventory that we currently track manually on Excel spreadsheets. We will be able to do this in an inventory system, and we should see some cost savings from that to be able to track those in real time and make sure that all the inventory is still in the proper place to where it's supposed to be, meaning screws and metal plates and all of that. So manually, you can lose some money. So we're excited about that.
Real quick on that one, so these are tried and tested because some of these programs that are sold that we found work great in one department, and not so great in other
You
departments.
mean for Q-Site
Right, it'd
necessarily?
be either one of those, both Workday, which one were we having problems with that? Which provider is it?
I believe that was for the permitting that you're speaking of, the
Yeah,
seller.
I mean, that was the thing, cause
So, yeah.
they sell it as a great program for everybody, and then certain departments, it's,
Yeah, and for Workday, it's an overall general, right? So
Okay.
the county chose Workday, went through the performance and all of the RFPs and stuff and chose them. So we just have to modify Workday to work for the hospital.
Okay.
So since our department is very unique, we spend extra time with the team building Workday to make sure that it's gonna meet the hospital needs.
okay, that was my concern, because
Yes.
sometimes
Some,
it takes
you
more
are
people-
exactly correct.
Takes more people to input the
Ex-
data than you're gonna save
Exactly.
doing
So what
it,
we're trying to do is to make sure that that's not the case, that we can make sure that we have processes which may view a little differently from other county departments, because ours is, there's a lot more volume that gets pushed through the hospital. So we just want to make sure we set up the workflow processes correctly so that we don't get behind.
So one of the big pluses for Workday is, you know, we sit right now with about 170 POs and
No, we sit about 350.
350, thanks, that's better, that makes me happy.
No, that's a day in the life
350
for me.
POs from
July.
July that we haven't paid because they're not in the system, and that's just, it makes us look like we're broke, and we're not, and we understand this is gonna fix this, right? That's what
It's
you
gonna,
promised me,
it's
right?
going, I promised you, it's gonna make it a lot better. So with Workday, which was what we can't do currently in PeopleSoft, is that we can enter in a 5-year contract 1 year at a time, and we don't have to go back and get a PO issued. Right now, we have contracts, which is your obligation to pay, but because of the mechanisms of county to be able to control the cash, we have to get a PO for those. So you're technically have an expectation to pay regardless, you have a contract. But we have to go through the process and get a PO in order to cut a check. That portion will go away. So all of our contracts, we will have a contract area in Workday, so we don't have to repeat that. So I'm not gonna say it's gonna be 100% perfect, but it's gonna make our life extremely, extremely better.
And then one last positive note, very positive for the hospital. One of our challenges has been with our neonatal, Jennifer Goodman. Should I take it? No. One of our challenges was the NICU. NICUs are usually very profitable in a hospital. Under the past leadership, we were running a census of about, an average daily census of about 7. Our census today with new leadership is 16, and we've gone from a money loser to a money winner. So that is one of the opportunities that we're very proud of. Now, don't tell St. Joe's, because I think we're taking them off from St. Joe's, so nobody bring that up, all right? But
That's a good thing.
We're very proud of what Dr. Cheng has done, and yeah, in a very short time, he's taken our census to over double digits. So good news.
that's better health outcomes, because that's one of the areas that we're not strong in San Joaquin County.
Say that again.
I said that's better health outcomes, because that's not one of the areas that we're strong in San Joaquin County.
And so quickly, I'll go through the rest of them. Strategize, which is the cost accounting system, which is required now by the state, is required.
Jennifer's calling me now, would
Oh,
you jinx
okay,
me?
okay. So it's required to be able to get the 166 million that you saw. It's a new requirement by the state for us to implement a cost accounting system, which is not a bad thing because it gives us more data. So, and then the last few, which is SSI, OPA, and CMARS, are all to do with the revenue cycle billing. The first is the billing, the second is the patient accounting system, and the third one that I'm really excited about will be a contract management solution for us. Currently, we have to do that manually, claim by claim, as payments are received. This system will allow us to do, every time we post payments, we can run a contract log to see if we were underpaid. And then we can follow up on that. Instead, right now, our representatives have to pull the contract and the contract matrix and manually calculate the payment. This will do it for them. So it will speed up that turnaround time in order to be able to get that bill back out the door and get the cash in the door. And one last thing I will say, I will end on a positive note. I will end on a positive note, which he's not used to. Another shout out to the revenue cycle team. When I got here 3 years ago, our AR days were 100 plus, which is not good. But with the systems that we have and the challenges we have, they have ended up in, whenever I calculated it for the last month, they were at 69 days. And a target for this hospital with the challenges that we have with the software systems, the target would be 75. You would see it at St. Joe's at around 45, but that's because they have different systems that can flow, like the contract management system, not having to do that manually. So we are very excited. I want to say thanks to the team once again. This is the lowest AR days that I've seen in 3 years.
And she's difficult, but probably one of our best hires. She's done an amazing job on revenue cycles. So.
Thank you.
Just from my side, even the financials from the clinic, it's nice to actually get the answers when we ask the questions, so that's kind of enlightening.
Okay, thank you.
Thank you.
There are no further questions. We will move on. Brandy Hopkins will present on the federal and state impacts.
So we actually wanted to open the floor this morning to talk about federal and state impacts. In our last presentation, we talked about quite a few of them. Our office will be working with all of our departments to report out on those impacts, and I would expect that next quarter we would provide a more robust report here in this room. But I am just actually opening the floor, both to healthcare services and to the hospital, to talk about anything we haven't covered so far this morning related to impacts that you're concerned about.
I think there's a whole lot of unknown. You know, I think that, and I'm not being political here, but I think if they hold out and get the subsidies to the ACA approved, then the challenges from the hospital are going to be a lot less. So we look at Medi-Cal, we understand the challenges there, but for the most part, we're not seeing any significant cuts, at least probably till the 2027 year. And there's a lot of time between now and then for those things to be fixed. One of the things that we tend to ignore, though, is there's a whole group of people, and I'm probably Uber drivers and anybody else in the gig economy, who receive their health care through the ACA. And if those those premiums are there's no joke. If they don't come and fix the subsidies, you're going to see premiums for those people double and somewhat triple, which means they just won't have them. The downhill effect on the hospital will be then we'll see more of the no pays, which is essentially free care. I believe that there's going to be a resolution one way or the other from both sides, because that hit to the population is just too significant. We talked a little bit about what we've seen right now. Very importantly, the only really decrease that we've seen right now is from the decline in the number of managed Medi-Cal patients from the non-legal immigrants that I think have either left or are no longer applying for those kind of benefits, because it exposes them to potentially being identified. So the only real the only real impact that we've seen now is about a 10% drop from the non-legals having access to care. And we will still see them. We'll just see them as a no pay in a much worse spot, because they haven't had the preventative care that we are all trying so hard to provide to the community.
From a healthcare services perspective, keep in mind there is 8 different clinical teams within healthcare services. So I'm going to first talk about the shutdown, and then Matt, if you want to mention anything about the clinics in terms of shutdown, and then the impacts of HR1. The biggest impact of government shutdown will actually hit behavioral health and public health, who both receive federal grant dollars. And so there are delay in payments based off of our mental health block grant, our substance abuse block grant, and all of the grants that public health gets for mandated services. So there will be, there's a belief we're going to get those payments back, but there is going to be a delay in the federal match or the allocations for those grants specifically to behavioral health. Behavioral health is going to get hit in the shutdown more than even the public health side. In terms of veteran services, everyday operations will not be impacted. However, the veterans who have pending claims are not going to have their claims assessed in a timely manner. So the Veteran Service Office, because of at large of claim processing, are on furlough or are less essential to process those claims. So our local veterans are not going to get their payouts as timely. So the everyday operations of veteran services are not going to be impacted, but our veterans in the community will be. So currently shutdown is mostly going to impact behavioral health, some to public health, and our veterans in the community. I don't know if Matt, if you want to mention anything from shutdown in terms of the clinics.
Sure, for the clinics, as far as regular operations, there's really a low impact. Looking at payments to providers, those should continue through at least the first quarter of 2026 without any interruption. Really the main impact would be for our Lodi expansion clinic due to congressionally directed spending projects being paused during the shutdown, but we're continuing to move forward with the lease negotiations, expecting that once the appropriations resume that we're expecting the drawdowns to restart. It might be a little bit of a backlog, but otherwise we're continuing forward.
In terms of HR1, there is significant impacts to public health. SNAP has already been completely reduced and eliminated altogether. There's also some significant changes in terms of other TB and other allocations from public health. Public health is the primary department that is getting impacted from the HR1 or Big Beautiful Bill within a healthcare services perspective. We are looking at about 7.5 FTEs that were funded through programs that will be impacted by HR1. So luckily there are vacancies, and so people are just being shifted into programs. That also does impact the hospital emergency response preparation that both public health and EMS does. Those funds will be completely eliminated by the end of 27-28 fiscal year. So we're already trying to figure out who's the right players to take on some of those duties, or if those things the county even still from a larger global perspective wants us to continue doing. And is that an OES function that has been historically under EMS and public health, or how do we share those duties at large? Luckily, we have 18 months or so to figure that out. In addition to HR1, there's some impacts in terms of correctional health and the new rollout of Cal AIM and Jail InReach beneficiary attachments and how the federal government will match for those dollars. The state has said that they are not changing Jail InReach and the reimbursement, but we do not know if the federal government is going to reimburse at the same rate for that federal match. In terms of behavioral health, the biggest impact of HR1 is in two different pieces. One is all of our supplemental rate payments for housing is through block grant, and anyone who is conserved but is currently not in good citizenship status, we will no longer be able to use those block dollars for. We are looking at approximately between immigration status and being able to qualify 90 individuals that will no longer be able to receive housing under behavioral health, which high likelihood would end up being in shelters or so forth. And so we have no idea how to pay for those individuals. There should be an impact to our hospital for those individuals who will most likely need services and so forth. In addition to that, there's 29.75 positions that will be at risk due to HR1 in behavioral health based off of recovery residence changes and payments to sober living and so forth. So the federal government is reassessing what that would look like in terms of reimbursement for sober living housing. And so we're looking at both positions, but a minimum of $5 million of impacts in terms of those that get supplemental housing or payment from behavioral health for primarily substance abuse residential homes. So the Be Well residential programs are okay. It's those transitional housing post-residential that will be drastically impacted. The other piece for behavioral health that we are concerned about is that we are anticipating our uninsured client base going from 13% to 33% by 2028. This will drastically impact outpatient billing revenue, but increase high costs for our crisis services and our deputy public guardian services, and the impacts of those who might end up being conserved due to changes in Medi-Cal eligibility and so forth. In order to combat that, what we are trying to do is build within the Be Well campus volunteer and employment opportunities. So those that are getting better and would transition from specialty mental health, potentially losing their Medi-Cal because they're starting to work, give them opportunities to at least have some form of employment through the behavioral health system in order to maintain at least another 6 months of Medi-Cal as they transition to another location, in order to make sure that they do not need our services at a later date. The biggest thought process that we need to consider also is, how will the state respond to the impacts of the federal changes, and how we might end up being drastically hit by the pendulum swing of how the state will respond to the federal changes. Because like Rick said, we have absolutely no idea what that will look like. But if everything stays as is, we definitely need to understand that revenue will decrease and crisis services will increase.
Are there any questions from any of the committee members? Other than that's a lot to take in. Okay, we'll provide, don't be sorry. No, it's too early for
Have
that.
coffee.
So here's some coffee.
I will just add that we know, we have been reading everything. We don't know. There's so much uncertainty, but our team, we're all on top of it. We are trying to prepare as much as we can for this. What that looks like, we're not sure yet, but that's why I think it's a very positive thing for our board to realize that there is so much uncertainty, and have allowed us to put certain funds in reserves, because we're going to have to dip into those reserves soon. I think sooner than later.
But one of the most alarming things was the 90 folks that are possibly undocumented that are getting behavioral health. So I mean, that's the big gorilla in the room, is how do you change that? The federal government's ready to pull the plug, but I mean, there's so many of those folks in California that do that. So what, you know what I mean? Then they're going to be more ill and go to the emergency room, and then they're going to cost us more money, and then it's not billable. I mean, that's the thing. And then the coding part of it, in the health plan, we saw that the amount of new coding is so out of control. How does that get fixed at the legislation, side of it? Because I mean, those are the things that I could see, and I come from washing cars, and I mean, I could see that now they've let things go so bad. Now they're over compensating to fix it, and then now you have to have all these people double checking, and and that's cost prohibitive too.
If you remember the United Health unfortunate murder of the CEO, United Health 38 out of 100 times denies claims. 38 out of 100. And when the board of United Health realized the significance of what happened, they got together and said, look, this is unacceptable. We can't, the communities, because the other health insurers, Aetna and the others, were bragging at being in the 20s. Well, it's still 1 in 5 patients we get denied. And when they pushed it with United Healthcare, when the board tried to push, United Healthcare said, don't do it. We can't survive without these kind of denials. And so it's not rocket science. It really isn't rocket science. They should just say, no, you can't just deny. Again, using the intubated patient as an example, that's just, I'm going to throw this into to the wall and see if it sticks, and see if they don't realize it, and we don't have to make the payment. So it's caused us to have, I mean, when you think about it, we have whole departments of people that are paid very well to deal with coding, which is insane. And then we have we have a denials meeting that we're late for right now, where we have a whole department of people that we meet every month with, trying to figure out how we can, what's the best bang for our buck in looking at the list of the denials that we have, to figure out which ones we can achieve to try to minimize that as much as we can. But it could be fixed very simply by saying, you can't do this. But again, we've been complaining as an industry for the last 15 years, significantly more so over the last 5 years. And I hate to say it, but it just, nobody seems to be listening, so. anyway.
Well, there's also a great deal of unfunded mandates, specifically in California. So if the federal government is not going to provide a federal match because it's a state mandate, it ends up being local costs. And so just the change, for example, of Care Court that got signed earlier this week, which expands those that are qualified for Care Court. That is costs that are going to impact behavioral health. It's going to impact county council, public defender's office, and the collaborative courts. And there was no input from counties, and in addition to anybody who's in Care Court, we are required to track Care Court participants until death. So even if they are only in the system for 30 days, we must provide data to the state until death. That is an administrative cost and oversight that is not sustainable long-term. But from a healthcare services perspective, what we have started to do is look at opportunities of where we're leaving money on the table from the federal government that we have not historically tapped into, such as MAW codes and other things that public health does, but a lot of the other departments can draw down those other funds. And so how do we learn lessons from each other in order to draw down federal dollars that we qualify for, but it has an administrative burden, but will that offset that burden in terms of the other administrative things that we have to do?
Thank you. Is that all? Anybody else have any questions or would like to add anything? Okay. Moving on, next Brandy is going to talk to us about the 2026 calendar. It's in your packet.
Just briefly, I think it's our last item. Annette's put the 2026 calendar together, so if you can make sure to get those dates on your calendar and note which ones are the financials. So she separated them on the calendar for planning purposes. Thank you.
Okay. So that's it for our information and discussion items. So up to public comment. Annette, do we have any public comment?
There's no public comment.
Okay, thank you. And any final comments from committee members? No? Yes?
Everybody, state of the county tomorrow, noon,
Thank
be
you,
there,
Chair.
be square.
Yes, and
And
some
then
treats.
We even have food, we
And
even
then
have
some,
food.
that's right.
And
And I did
swag.
ask if it was on your
And 28
calendar.
county departments on showcase that, so it's gonna be an amazing.
Hopefully your departments will have a booth there, that'll pop up.
Yes.
Okay, perfect, thank you. So there are no closed session items scheduled for today, so we can adjourn at 10:08. Thank you. you